the chairs and the ranking members. I'm Senator Matt Lesser. I am the co-chair of the Human Services Committee. And this is a follow-on to a meeting, I believe last week, that the Insurance Committee led on the the Medicaid redetermination process that's going to be beginning starting in March. And we had a lot of interesting conversation with the Department of Social Services and Access Health. We decided to have a follow-on meeting hearing from some of the provider community, as well as having an opportunity to talk as well to DSS and Access Health, get more information about planning and make sure that we have a good dialogue with legislators, with the healthcare community to find out what we can do to manage the redetermination process. And with that, I'd like to turn it over first to my co-chair, Representative Gilchrist, if she's on. Representative Gilchrist? I can't see who's on very well. And are the, well, I will turn it over to Representative Wood from the Insurance and Real Estate Committee. Representative Wood, good to see you.
Thank you, Chairman. It's great to be here again on this extremely important topic. Thanks for organizing all the people that we're going to hear from today, and looking forward to the discussion.
Is Senator Cabrera on? Is Representative Jay Case on?
I'm here, and Jillian should be here. Oh, there she is. We're all just coming off another meeting. Matt, welcome, and looking forward to hearing what's going on.
Excellent. Representative Gilchrist?
Yes, thank you so much. Sorry we were late. Looking forward to the presentations and learning more. Thank you.
Terrific. Is Senator Seminar on?
Yes, I am. Thank you so much. And I look forward to hearing the presentation as well.
Representative Wood, I'd be happy to, if you want to turn it over to your ranking members as well for any comments that they might want to have.
Thank you. Representative Pavlock D'Amato. Representative Wong, or I'm sorry, Senator Wong. Okay, we're ready to go.
Okay, great. So the first item of business is we're going to hear from a panel of providers and advocates. Rather than just talking about what we're going to do to you, I want to hear about what we can do to make sure that the redetermination process works better. And so hearing from the ground about how things are rolling out, if there's specific ideas that you have about how we can work together and speed things up and make sure that there isn't a loss of coverage or gaps in coverage for folks on the ground, I think would be really helpful. So I wanted to hear first from the provider community, and if we could each have you speak briefly. We've got a pretty big panel here, and so we're going to have to move pretty quickly if we can. So please keep your remarks short and to this conversation. And so we have before us Matt Barrett from the Connecticut Association of Healthcare Facilities, from the Community Health Center Association of Connecticut, Sarah Lamaster and Gilda Descala from Fairhaven Community Health. From Leading Age Connecticut, we've got Mag Morelli from Community Health Center Inc. We've got Marie Yardis, and from the Connecticut Hospital Association, we've got Mark Schaefer. Mr. Barrett, do you want to go first?
Yeah, thanks so much, Senator Lester. First, I'm so grateful that you and the leadership at the legislature are putting a spotlight on this issue. I've been watching from a distance, and I heard it described in the provider community and the advocacy community as a period of panic. I don't know if I would go that so far, but certainly there's a certain amount of anxiety when you're talking about, 1 million people on Medicaid. And while I'm principally focused on the long-term care services and supports population, which is not just skilled nursing facility, Medicaid finance care, but also home and community-based care. And there's 45 or so thousand people receiving services there, principally home community-based services. They represent the lion's share, but there's some 15,000 Medicaid recipients in skilled nursing facilities. And so in the interest of time, I want to launch right into some recommendations. And that's that. And by the way, that isn't to suggest in any way, shape, or form that there hasn't been some amazing planning and work going on at the Connecticut Department of Social Services. I think we should be really reassured that there was early intervention in here and so forth. But I think that and I'm not even suggesting that DSS isn't working on what I'm going to be talking about, but I think we need to be talking a lot more about shifting the burden from the clients and the provider community back over to the government in terms of using whatever means possible that they have at their disposal to maximize automation and increase renewal rates. And I'm talking about something that we often refer to as ex parte renewals, or sometimes we hear them referred to as passive redeterminations or automated redeterminations. And there's a whole body of practice that suggests that we can make a lot of headway as we're unwinding if we do more and more automation and more and more passive redeterminations. What I'm talking about is the government first makes its own attempt without contacting any clients based on a lot of information that is available to them already concerning assets and income through cross matches and data matches and bank account verifications. And they are able to determine that there's a presumption that eligibility will be ongoing. And we keep eligibility going in a continuous way rather than terminating a lot of cases on the other as we're moving towards unwinding this process. So really, I've got a paper on it. It's not anything that I've authored. It's actually a CMS paper that talks about strategies to renew eligibility under this ex parte renewal process. And I'd like to see, I'm recommending a lot more focus and attention on that as we're moving towards the other side of the public health emergency.
Thank you. The next person we'll hear from will be the Community Health Center Association of Connecticut, Sarah Lemaster and Kilda Discala.
Hi, and I'd like to thank the chairs of both of these committees for hosting this forum. We're both really excited to see that this is happening and that the legislature is putting an intentional focus on this particular issue. I wish I had as much optimism as the speaker before me, but we're concerned. There are two large concerns that health centers currently have. One is that there's a very significant barrier that currently exists for Medicaid enrollees that do not have a social security number. So this is newly eligible Medicaid enrollees. Currently, CACs at our health centers cannot complete any applications for those enrollees. Every single one of those applicants has to complete an application through DSS. We're very concerned about the barrier to care that this represents and the additional burden that's being placed on these particular patients. And we're also concerned about the Medicaid, the PHE unwinding. Medicaid applications currently require a large investment of time and staff resources to complete. In some cases, they're taking 1 to 2 hours to complete. Simply speaking, CACs at our health centers do not have the time or capacity to process applications given the current or assist patients in processing applications given the current situation. So we are really focused on streamlining the application process, making it as easy for patients and our certified application counselors as possible, and really figuring out where the bugs are in the system so that it is simple to complete the application process, but so that it's simple to access the application on Access Health's website. There should be one button that you click for Husky. So I'll conclude my remarks and invite Gilda to give you some perspective from Fairhaven.
Good afternoon, everyone. So speaking from the perspective of a CAC and trying to assist our patients, the process is extremely lengthy. We are online submitting information, but 99.9% of the time we get bounced off of Access Health's website, where we have to pick up the phone and then call and have someone process the application over the phone. Just to be clear, we do not get to enroll the patient. We are there to assist them, to guide them, to help them do the process, but we don't have the same access as as Access Health and the call center, their call center. So really what we're looking for, and we want to help our patients. We want to be able to streamline this process. We have numerous amount of CACs on staff, and we're looking to see if we can get some additional access to be able to help process these applications, and not necessarily eliminate the middleman and have such a high level of access where we can do overrides, but really simply be able to get past the manual part of things, having to get somebody on the line. It takes over an hour to get this going. So really, that's really what we're here for. We're here to help our patients. You know, our patients know us, they trust us, they're coming to us, and we want to be able to assist them. And the way things are going, the amount of time that this is taking, we can only get to a few patients a day, and that's just not going to be feasible once the unwinding starts.
Great, thank you very much. Next, we're going to hear from Ms. Morelli from Leading Age Connecticut, and we'll have an opportunity to ask some questions after everyone has spoken.
Sure, and thank you, Senator. And sort of piggybacking off of Matt, because we serve the Husky C population. So because the Husky C, it's such a lengthy application process initially. You have the 5-year look back. It's quite extensive. That really takes a lot of time. That's why the thought being that the passive redetermination would be, really apply to this population very well, because they've already gone through the whole extensive spend down 5-year look back to apply to become eligible for Husky C. But one thing Matt and I have talked about is, and we've actually reached out to DSS, is a need to get back to basics with our teams in the nursing homes in particular, to remind them, and for many of them train them or retrain them because of the turnover we've had, the whole redetermination process, the rep payee process, what they need to do, what they need to look for, because they're going to be assisting families, they're going to be assisting conservators in doing this redetermination. So we've already reached out to DSS, hoping that we can do some education on our end of our staff to remind them, the basics of the redetermination. The other thing we've realized in all of this and talking to our members is that there's something called minimum essential coverage, where some people who did not respond to the redetermination may have lost their Husky C, but maintained the lower Medicare savings program. So we're also going to do some outreach to make sure people get back onto the Husky C, get people to understand what might have happened during the pandemic and why they maintained one level of coverage but lost the other. So we're going to do some outreach on that too. So we have a really good history of working with DSS and putting on these training programs, and we're hoping that we can do one right away.
Thank you. Next up is Ms. Yardis.
Good afternoon, everybody. I'm so excited to be at the table with all of you. So I can say that the information provided by both Sarah and Gilda pretty much match our experience at CHC. Along with what Matt had said, really thinking about what that response timing is. Obviously, as a federally qualified health center, we're thinking about revenue protection, right? What is the demand for an organization that has 70% Medicaid patients? If that response takes weeks or months, what does that look like as far as the in-between? Our staffing right now really is an existing team of access to care coordinators that are all certified application counselors under Access Health. But then we've had an opportunity to obtain grant funds that's allowed us to increase staffing. So the Connecting Kids to Coverage, keeping Covered Connecticut, any opportunity we have to increase staffing, that's really the goal. What we can't do on our end is improve the process, which is, as others had said, the length of phone conversations. I have team members who are on with Access Health or DSS for an hour and a half to 2 hours. They have other responsibilities, to patients regarding connecting to resources, social determinants of health, right? Not to mention SNAP applications and other things, on the list. The question really for us is, how do we prioritize populations? Is Connecticut going to do that in any way as far as those who most recently applied and were active for coverage? Is it going to be those senior and disabled? Is it going to be children? We're trying to think about our outreach opportunities And really, how do we connect with everybody? And, what are the easy lifts versus those who may need a higher level of engagement? The process, as others had said, with the call center and the online application, it's very laborious. Not to mention, there is a question for our team, how well trained the call center at Access Health is. I don't want to pinpoint any specifics, but it seems that sometimes the reliance on the system itself is prioritized over the information. So we could have families on that we know are eligible. The system is saying that they are not. And then there's next level, right? Supervisors, appeals, things of that nature, where I really think the conversation could be, or the staffing could be better informed and not relying on just what the computer is saying in front of them. As for our kids recently, our undocumented children who are recently eligible, we've had a little bit of a workaround in terms of being able to say, yes, they are applying for citizenship. This may not be the case, but we have found that that really is the only way to get them through the application process. There's something that has to be documented in the system in order to greenlight that. For us, we're also looking at application software, systems like Advocacia, where we can communicate with patients through that system, send them links for signatures, document upload. It will integrate with our electronic health record and allow us to have that auto populating of information if it's not going to be available through the state. But everything comes at a cost, right? So really the question remains of what can we actually accomplish, prior to and then at the very start of the unwinding of the PHE, and then how can we consistently support our patient population. So I appreciate all the feedback from today. I'm looking forward to it.
Thank you very much. And last up, we have Mark Schaefer from the Connecticut Hospital Association.
Thanks a lot. I am delighted to be here. I have comments just to make on three areas of this challenge. One is why it's so critically important. The other is what I see as one of the most significant barriers we face. And then the third is to add a few additional ideas for consideration. I think that, to my mind, there's no question that there is a need to invest resources and to be bold in the investment of resources to ensure that the risk of several thousand people having a sustained disruption in coverage doesn't happen. For me, the interests of patients are foremost at this point. There is a disruption in coverage means that people will forego essential preventive services and may avoid going to healthcare settings, which are essential for early detection and early intervention. And what we saw during the pandemic is that people put off getting essential care, and we're seeing the costs of that now in terms of increased acuity, cancers caught far later than they could have been, uncontrolled diabetes and hypertension, both of which have gotten substantially worse since before the pandemic. So from a public health perspective, I think it's critically important to make these investments to protect health. It's also important because economic security is a factor in health, and people could incur uncompensated, basically incur medical costs that add to the burden and the stress that they're already feeling in the face of inflation. And with regard to the burden of inflation, there's also what the provider community is experiencing. So as you know, hospitals, FQHCs, and others pick up the uncompensated care costs of many, many individuals. We are collectively, as care delivery providers, nursing facilities included, experiencing unprecedented levels of cost pressure. Hospitals are incurring $3.5 billion more in costs post-pandemic than we were pre-pandemic. Inflation remains a headwind. And while we are there to provide care for everybody who needs it, it will add strain to an already overstrained care delivery system. With regard to the barriers, the barrier probably that is foremost in my mind is that of workforce at the department. So in the wake of early retirements last summer, I know that Peter Hadler and the team at DSS are working really hard to rebuild the eligibility assistance capabilities, but that takes time. Even as staff come in, they don't necessarily have the expertise when they hit the ground to be able to process applications or be responsive in the way that they were before the early retirements. And so necessarily DSS has had to cut back on office hours and that sort of thing just to manage the flow. Hospitals have experienced challenges with eligibility assistance in the past number of months. Peter and the folks at DSS have been very responsive to addressing those needs, but the lesson there is that even before the unwinding begins, we're in an overstressed capacity with regard to early retirement and the eligibility assistance workforce. So in addition to the process improvements that I think have been a focus, doubling down on passive enrollment, ex parte processes, I think Connecticut's a leader already in that, but there may be more that can be done, as Matt Barrett's paper may shine a light on. One of the things I think we should consider is whether we should adopt some of what Rhode Island is doing to allow for passive enrollment for folks who don't qualify for Medicaid, but qualify for a no-cost Access Health Connecticut plan to be auto-enrolled in an Access Health Connecticut plan, and even to consider some sort of incentive or premium subsidy for a short period for folks who qualify for a plan with some cost share requirement. The other thing that I would ask be considered is that we really double down or reinvest in some of the assister type outreach and engagement capabilities. The stories that have been shared so far make clear that even through process improvements, it's a high touch process to work with folks who don't have Social Security numbers, who may have health literacy barriers, who are struggling with their own social determinant challenges, to be able to help them to navigate an extraordinarily complex system and to be able to get signed up or redetermined timely. So I would encourage the state to consider any opportunity there is to resource community action agencies, FQHCs, and various care delivery settings, hospitals and others with assisters and navigators who can help on the ground with the folks who need to get redetermined. So thank you so much for holding this forum and for inviting our input.
Great. Thank you to all of the presenters. There was a lot of information coming at us fast and furious, and you were also all concise. And so really appreciate that. And we do want to get to DSS and to Access Health. Specifically, Mr. Barrett, you mentioned ex parte renewals. I know that they are already doing passive renewals. Can you just speak briefly if there's more that they should be doing or could be doing in your?
Yeah, I can speak. Senator Lesser, I could speak specifically to the long-term care services and support population. But I think my recommendations may be relevant across the entire Medicaid population. But take the age blinded disabled component of the Medicaid program. They have gone already through a very rigorous upfront initial eligibility determination that involves a 5-year look back period evaluation of assets. They've already been determined categorically eligible. It means they are under a category of persons that are eligible for Medicaid, and they've gone through this rigorous income and asset evaluation. Because their situations could be characterized as stable, whereas their income is not changing really much other than annual cost of living adjustments, and their assets are not changing much unless there's, in the rare case that they would have come across a windfall, they are very likely eligible and will in an ongoing way for Medicaid, yet they often discontinue or terminate at redetermination for what I would characterize as procedural reasons. What do I mean by that? There has been a failure to return the application. Now, those applications don't often go to skilled nursing facilities, except for when they are the authorized representative. They're usually going to the recipient directly themselves, or to a fiduciary, a conservator, or perhaps a family member. And one of the main reasons they discontinue or terminate at redetermination time is the failure to return the application in and of itself. And so it's almost a near certainty that in actuality, they're still eligible for Medicaid, but that we end up in a system where we are recycling through the intake process because we have really inappropriately redetermined. So a passive redetermination process where it falls on the government. And I know this probably isn't going to make me popular with the government, but we believe they have so much information available to them that they can cross-match and make it be reliable and a determination that this person is probably very likely continue to be eligible. We're going to continue their eligibility under this passive process and determine eligibility ourselves without even the need to contact the client initially. Now, there is the opportunity to follow through and verify eligibility in a more detailed way if they are not able to make this reliable determination. But that's really what I'm talking about. And to the extent that that is occurring successfully elsewhere in the program, I guess I'm not really intimately aware of that. I know it is not happening in the very stable age-blinded disabled population that we're most familiar with.
Great. And then just for the presenters from the health centers, we have I think 3. There was a lot of talk about CACs and how we can better use them to assist with the unwinding the redetermination process. Sounded like, do CACs have to call the same call line as the general public? Is that really how it works, or is there?
Yeah, they can use they have a CAC identification number where they can sometimes skirt around and hold for a shorter period of time, but hasn't been entirely that fruitful for my team. I can't speak for others.
And they have to call and speak to someone in the call center just like anything else, even if mine is different.
Correct. Because we're using the consumer portal. We don't have our own portal to go through.
Right.
And it are there others? Does Access Health have their own CAC? Is there another way to do this? I mean, obviously standing up a new technology in a month might be tricky, but I'm just trying to think if there's another model that's out there that might be easier for you all to use, so we're not all clogging the same call centers.
One of the ideas that was floated by Gilda and others at our health center was to create a sort of super certification or a different certification so that CACs at health centers could sort of bypass some of the issues that they're experiencing, or have them at the same level of certification or same level of credentials that people in the call center do, so that it removes the need for that, or to have Access Health employees available to be at health centers to help process enrollments. There needs to be an expedient way, I guess, to process those applications so that they can be done as quickly as possible.
Okay,
it doesn't make a ton of sense to have them go through the training and certification process and then not be able to actually approve or deny applications that they're working on with patients.
Agreed.
Are there questions or comments from members of the committees? I think I saw a hand up. Oh, yes. Representative Wood.
Thank you, Mr. Chairman. So I guess what I'm hearing is that the passive or automatic redeterminations is something that would help solve most of the issues here. So I'd like to get some feedback, in our next segment on if we can move towards that. Also, the Access Health website bouncing people off, is that a technical issue? What is that issue? Is it just on one side your poor internet, or is it actually the website having issues?
So I can answer to the Access Health bouncing us off. We can start an application online, and even someone who has a valid social security number and is validated, they bounce us off stating that they have to validate identity. So we have to pick up the phone and call in anyways. and start the process all over. Yep.
Yeah, I mean, that just sounds like a lot of work, redundant efforts and timing. And it seems like something that can be solved, through the website. So, I mean, you've offered a bunch of solutions, which I think is great. Just to follow up on the training for the Access Help call center people. I think, again, that's another solution that you offered that I think, we could dive into. So I just want to thank everyone that spoke, because you gave us some concrete things that we can do to make things more streamlined and less of a headache and less of a time constraint. Thank you, Mr. Chair.
Thank you, Representative Gilchrist.
My question was for Mag Morelli, but since she had to leave, I'll just follow up. Thank you, Mr. Chair.
Terrific. I think that's all we have from Representative Johnson. I'm sorry, there's something weird on my end seeing whose hands are up, and I apologize.
No worries. Thank you so much for this. Sorry, I'm a little late. My question, though, has to do with the last few remarks with respect to the automatic redeterminations. And I just wondered how that fits in with the audits that we run into. And would we need to take a look at what the auditors want to have us do in terms of redeterminations? And that might have been covered, and I apologize if it has already been covered. And also the problem with doing the redeterminations, how do we deal with people who have dementia and don't quite get the applications done or don't do the redeterminations? And I think that I've run into that as a problem in my district. So those are the questions that I'd love to have the Department of Social Services answer, because they fit into some other problems that I'm running into. Thank you so much, Mr. Chair.
Thank you. And I see Mr. Hadler from DSS has his hand up. We were planning on hearing from DSS and Access Health in the next portion, but if you would like to weigh in here, I certainly can, and obviously we welcome you responding to any of the anything that we heard in respect.
Thank you, Senator Lester. I would be happy to talk about any number of the issues that were raised. I just wanted to say that we do have a lot of information about passive renewals in the presentation that we prepared, and I just wanted to make sure that we have an opportunity to talk about that, since it's such a topic of interest, and it is a very important thing for us during the unwinding. So I've got some good news to share on that, and really want to be able to talk through the numbers and the details. My understanding is that was a big question that was left looking for more information at the last session. So we have that, and just want to be able to talk to it. Thank you.
Great, absolutely. I think that is exactly what we want to hear about. And with that, I'll close the first panel, and we'll go on to the second panel. And I think, Peter, I think you're up first. So go ahead and talk. You and Morgan Leary are here from, and then also we have Jen Mersaci.
Yes.
And then here is afterwards from Access Health.
Excellent, thank you. And you're correct, Senator Lesser. Morgan and Jen are here with me from DSS. Morgan Leary is going to help me walk through some slides. Some of this may be a repeat for some of you. Just wanted to give some level setting, of course, and give you the latest updates on unwinding. And as I just mentioned, to sort of really dive into the renewal projections for the unwinding, and share a little more information about the passive renewal processes and what those look like. Thank you, Morgan. If you want to go to the next slide, we can start moving through these. So as many of you know, we've been talking about PHE unwinding for quite a while. The key thing that we're really talking about today, and that is the heaviest focus for the unwinding process, concerns the continuous eligibility enrollment provision in Medicaid. The end of this continuous enrollment requirement was set through the Consolidated Appropriations Act, which passed Congress at the end of December. And starting on March 31st, 2023, we will be, quote unquote, returning to regular Medicaid eligibility processes. But I really want to stress and emphasize that this is a year-long process. People will not lose eligibility starting on March 31st en masse. That is not the way this is going to work. Everyone's going to have an opportunity to go through a full renewal process if they've been part of the extension during the public health emergency. So we will be evenly, to the greatest extent possible, putting people into new eligibility cycles so that we can handle that process accordingly over the course of a one-year period. I also want to stress that 98% of the households who've been extended during this provision are in Husky A and D, otherwise known as Magi Medicaid, which the department administers through our shared operations and systems with Access Health. I also wanted to just quickly note before we get into more of the details that there is an update to be made about some of the new limited benefit coverage groups that we had during the public health emergency. The Medicaid COVID-19 testing coverage for the uninsured and our parallel emergency Medicaid that we set up during the pandemic, which have allowed individuals who have otherwise not qualifying for insurance to be able to access COVID-19 testing, vaccination, and treatment, is closely tied to the federal public health emergency declaration. And just 3 days ago, the Biden administration announced that that declaration is going to end on May 11th, 2023. So that will be the end date of coverage for that population, and has some other associated work for the department as it relates to other programs that I'm not going to get into today, but I just wanted to note that while we've been watching for this date for now 3 years, there actually is a date that is associated with the declaration, even though it has been decoupled from the continuous eligibility provision. Next slide, please. So you guys may have seen this before. I'm going to touch on it very quickly. This is our key state activities as it relates to the unwinding of the continuous enrollment policies. The Consolidated Appropriations Act, again, was enacted on December 29th. We've begun conversations with CMS, reading left to right on this screen. There are several things around February 1st, 2023, which are not relevant to Connecticut because we are not opting to be in the first cohort of states who've opted to start the unwinding February 1st. We are going to start our unwinding for renewals on March 1st. And so on February 15th, because we are initiating renewals in March, we'll be submitting our redistribution plan, our system configuration plan, and system test plan and results. So this is purely from the DSS perspective, just to share some of the things that we are tracking and the work that we need to do as far as intersecting with our federal partners. On March 31st, the continuous enrollment condition expires, and starting in April, determinations can begin. This is associated with the wind down of FMAP as well. Next slide, please. So this is an important slide that I want to make sure that everybody understands and hopefully gives some insight into the way that we are planning to do this work. So Connecticut is distributing renewals over a full 12 months of unwinding, and this is called a staggered approach. And we're doing a staggered approach with a time-based methodology. We're going to take all of our renewals, we're going to spread them over a course of 12 months. The time-based methodology works in that the households who have gone the longest without a full eligibility review are going to be reviewed earlier in this 12-month cycle. So we're taking all the population that has had an extension during the public health emergency and hasn't gone through that full renewal process and setting a new renewal date for them to complete a renewal. The first batch that's going to come up in March is going to be comprised of households that were extended in March, April, or May 2020. The April batch will include June, July, or August 2020, and so forth, all the way through to the current folks who are going through a renewal process. It's really important to note that households who have been extended under this provision are going to be given the opportunity for a full renewal evaluation in their designated renewal period. This means that even if they haven't reached their, if they're not in the renewal period and they come and report information to us, we won't be acting on it until they've had that opportunity to go through a full renewal. And I also want to re-stress that this is all about the Magi and Medicaid CHIP households. This is what we're really talking about. And that is the Access Health shared door that DSS and Access Health administer together, which is where people will be going. And that is the Access Health website and call center. And you can see the image on the bottom that sort of plays out. You may have seen this before. This is the 12-month staggering. And I will note that there are 2 months in blue on the far right end, March and April of 2024. CMS recognizes that the renewal cycle does take time to wrap up. And so they allow states an additional 2 months to complete renewals that might be pending during that time. Next slide. So how does this look for a client and for a system perspective? The renewal cycle is approximately a 60-day period. So when I talk about a March batch, we're talking about people who will be identified right at the beginning of March, and we'll have a 60-day window during which we'll be taking action to evaluate whether they're eligible for a passive renewal using electronic data sources such as the Connecticut Department of Labor, IRS, and SSA to compare it to the self-attested information on file for that client. If we're able to match the data that we have from the client with the data that we have from our electronic sources, they will passively renew. If there is a mismatch or the data sources are indicating, for example, that they have income that is in excess of the program threshold, then they go through a manual process. So that takes place behind the scenes. Strictly at DSS, we are bouncing everyone's information off of the Federal Data Services Hub. We're running through this ex parte process, which is required, and that we perform for everyone. And then 45 days prior to the renewal date, if they've been successfully passively renewed, they get a notice that says that they do not need to take action, but they should tell us if anything has changed based on the information that we have. If they take no action, coverage will continue. If it's not a passive renewal, they will get a pre-filled renewal form with all the information that we have on file for them. It gets mailed to them, and they will need to take action in order to be able to continue benefits. And they can contact us through, online, by phone or paper. I want to emphasize that, to the extent that we're all sharing this messaging and trying to make this as efficient as possible, for households who can renew online, it is the best channel. It is a real-time eligibility determination, and it reduces our operational burden because there's no work or intervention required in order to be able to complete the process. Next slide, please. So I think this is a dense screen of information, but it is really important. And I want to spend a few moments walking through it because I think this is sort of the key to understanding the operational impact of unwinding as it relates to the extended population for Magi Medicaid, which again is 98% of the extended households. What I'm showing you here is some information on the top rows of data about the renewal volumes that we handled during the regular process over the past year. So we are having, and you can see the renewals in the regular cycle is the first column that has data. There are no renewals in the extended cycle because those are the people who we are going to be handling during the unwinding process. You'll see their information coming a little bit further down the screen. So in the past calendar year, which is the same, roughly the same calendar year for the unwinding coming up, we handled 27,000 renewals a month as part of our regular renewal cycle. Of that population, nearly 15,000 passively renew, which is about 54% of the entire population. So every time we go through a passive renewal process, 54% of people are automatically renewed and need to take no action to continue their coverage. The converse to that, we're calling the manual renewals. So you can see that 54% of them are passively renewed, 46% are going through a manual renewal process. The reasons that people don't usually pass the passive renewal process is related to their income. So you'll see that the number that failed for income reasons over the past year was 39% of the population, or averaging about 10,000 a month. And this is where the major changes have occurred in our system programming to ensure that we're maximizing ex parte passive renewals. We are going to bringing that number up very significantly through some changes that we have identified during our planning for the unwinding, and really going to reduce the number of households who fail for income reasons. So you can start to see in March, one of these fixes is already in process, and then in March, we'll have the second phase of our income fix going in. And you'll see that the number in March alone, in that far right column in light blue, goes from 11,700 individuals failing for income reasons down to 5,000 people who are failing for income reasons. 6,000 plus more people are going into the passive renewal bucket and will automatically have their eligibility continued through this process. What does this mean in the big picture? If you look at the bottom row, we are going from a 54% passive renewal rate to a 70% passive renewal rate for all households across the board during the unwinding period. This means that the converse to this, the total manual renewals, which were averaging about 12,500 a month for the past year, during the unwinding are expected to be 13,500 a month. It is only a 9% increase in the volume of manual renewals compared to our regular average volume over the past year. So we are really, I think this is really critical to understand, that these changes that we've made for passively renewing households should result in a tremendously reduced operational burden compared to when you look at the total number of renewals that are being handled in any one cycle. So the renewal volumes are up, and they're going to be up a lot because a lot more people are going through the process. However, a significantly higher percentage of people are going to be able to be passively renewed, and the number of manual renewals that are coming out as a result are pretty much just status quo, a little bit higher than average over the 12-month period. And I also want to point out very quickly before we move to the next slide that the peak months for total manual renewals, which are right around 17,000, that is what we normally handle in manual renewals during open enrollment periods. So this is not an unfamiliar level of volume of renewal work, and it is something that we're prepared to staff up to during the unwinding period. We'll be maintaining open enrollment levels of staffing for the unwinding period in order to be able to address this. Next slide. So to take some of the points that I was just emphasizing on that last slide, boiling down to some of the key takeaways, the projected monthly average of households that are due for a renewal during this unwinding period is going to be up 68%. There are a lot more households that are going through a renewal cycle than usual. However, the passive renewal process is 118% increase during this period, because a lot of those households that previously were extended and were not able to be passively renewed will now be able to be passively renewed. So finally, the projected monthly average they're going to have to manually review with Access Health is a 9% increase month over month compared to the prior calendar year's average. And as I noted just on the last slide, that's equivalent to our open enrollment volumes during the highest months. Next slide, please. Also wanted to draw attention to the other coverage options for people who may not be able to renew and stay eligible in their existing Husky coverage group. For a significant portion of the population who's had an increase in income during the pandemic that might make them no longer eligible for their Husky coverage, they will be eligible for the transitional medical assistance coverage, which is an additional 1 year of coverage for households, for Husky A households who have increased earned income. We're estimating that of the population who is likely to be over income for Husky now, about 51% of them are going to land in the TMA coverage group. So they will continue to have Medicaid Husky coverage for an additional year. The data does not include children, because the children can stay in Husky A up to a higher FPL than their parents, 201% versus 160% for the parents and caretaker relatives. The children can also subsequently, if they no longer meet the 201% threshold, can fall in the Husky B CHIP bands up to 323% of FPL. And if they're over income for that, then they'd likely qualify for TMA. So we do not anticipate many children losing coverage in the Husky A group. Finally, of the remainder of the people who are likely to be over income during this process, they are likely to be eligible for coverage through Covered Connecticut, no cost coverage through the new program that we've instituted, or low cost coverage through a qualified health plan. And I believe that my colleagues at Access Health have got additional data on where they're projecting some of that population to land. So there's a little bit more information to come later today about the projections for people who may no longer be eligible for Husky. Finally, I just wanted to emphasize that consumers do receive a real-time eligibility determination for all forms of coverage through Access Health CT. Connecticut is a standout in state processing of eligibility. Our real-time eligibility allows 99+% of people who are in Magi coverage groups to be determined in real time, online, or over the phone. Basically, it should be a one-time contact with updated information to be able to get an eligibility determination. Next slide, please. So I think that there, and I apologize because I wasn't at the last meeting, but there was some interest in how the data would be presented about the public health emergency unwinding. And I wanted to identify that there are a number of reports that are required by CMS during this process. These were augmented during the Consolidated Appropriations Act. New requirements were put on states about how they would report on unwinding. Some of the things that we're required to report on are the number of renewals initiated in a month, the number of individuals who are renewed or terminated, those who are terminated for procedural reasons, the number who are transferred for enrollment in CHIP or through the exchange, and the number of individuals who made a qualified health plan selection. And this information will be made public by CMS. Next slide, please. So I wanted to pause right here. We have a number of outreach strategies. I know you guys have heard some things about this. I'd love to go into this a little bit more. I can move very quickly if that's of interest. But I also wanted to perhaps pause and see if you wanted to talk a little bit more about the passive renewal operational processes before we talked about some of the outreach and communications work that we're doing.
Yes, I think we would, and specifically if you thought there was an opportunity to respond to any of the or any of the other comments you've heard from the providers earlier.
Yes. Sorry, I just lost my screen for a moment there. I do have some things that I think would be helpful to circle back. And I was trying to take some notes as everyone was talking. And I think we've been in conversations with everyone who spoke today. So we are working on some of the proposals that have been suggested, and we're aware of some of the concerns. I did want to also note that while the presentation and the information being provided has a very heavy focus on our MAGI coverage groups, because that is where the vast majority of people who are going through an extension have been located, we do passive renewals across the board. We've got about a 50% passive renewal rate for Husky C and about 80% passive renewal rate for MSP. So there, we have a very consistent and an increasingly good passive renewal process for that Husky C population that Matt was referring to. There's always potential for improvement. We continue to look at that process. We've really been able to expand the number of households that we're able to passively renew because we instituted a new asset verification system behind the scenes, where we're able to take clients' bank accounts and records and match it up against the records that we're able to access through electronic sources to confirm people's assets. That's often been the biggest challenge when it comes to Husky C, is asset verification can be quite complex. And as you know, our asset limits are not very high. So it doesn't take much for a household to be able to be over asset, and we have to continue to evaluate their ongoing eligibility for services as a result of that. I also wanted to note that the concerns that were raised about the online process for applying for Access Health related to Social Security numbers. This is a requirement for us to be able to prove identity of a person who's applying for benefits. It is mandatory that we prove identity. It doesn't necessarily have to be through Social Security number, though that has been historically the best way to get the fastest determination for households. The challenge that I think that we're seeing now pertains to the new state Husky coverage. And we know that the population has very few Social Security numbers overall. And so as we put out in our guidance to providers and to clients, when they're applying for the new state Husky coverage for the children ages 0 to 12, they need to be able to apply over the phone or by paper. We're going to continue to work on refining the online process because we want to make that a valuable door for everyone. But it is simply something that we have not been able to redesign in time to be able to offer the online access point for those clients at this time. So I think it's a fairly narrow category of households. I'm sure it is of feeling of an outsized effect on our partners in FQHCs right now. The program is new. We're all trying to get lots of people to be able to access the coverage that they're eligible for. And it's a challenge because, for many households, the normal process was just to be able to go online. And it was pretty seamless. It has worked quite well. We haven't received any other concerns about the system not being accessible other than through this Social Security number issue. And we understand that it's magnified right now because of the state Husky population that folks are trying to enroll. So while we work on that process, we do have to emphasize that the best way to be able to apply for state Husky is over the phone. Or through paper, which will allow us to process associated exceptions to Social Security number to be able to confer that eligibility.
Peter, I have a question, but I see other hands are raised. I wanted to follow up on what you were saying, but I don't want to interrupt those who were raising their hand before me. Okay, I'm going to ask then. So you were just, talking about our undocumented children. One feedback from my team is even though they are using the phone system through Access Health, our applicants are being directed to send in a letter, submitting support letter about legal status, which they don't have anything to prove. It's creating a lot of stress for our families. We don't know how to guide them. What exactly are they supposed to submit? And I think with this population, we have to be considerate of historical issues. This is a fear-based, process. They're in terms of public charge, histories around that. The more information they submit, I think the higher the fear increases, goes up. So I don't know what your feedback is around that, because we are using the call center and it's not really providing much in terms of direction.
So I will just quickly, before I pass it back to Senator Lesser to sort of figure out the order of folks who are asking questions and how we respond. I just wanted to quickly say, we can talk about that some more. We've provided some information on our website about how to go through those processes, but happy to talk to you about, refining if you're encountering specific kinds of issues, how we can address that and ensure that everyone is informed about the proper types of information that is required or not required to determine eligibility for that program.
So in the interest of good order, why don't we just move on with the DSS presentation? We'll hear from the other folks from DSS, open it up to some questions. I see there are a bunch of people with hands up, and then we'll go to Access Health, and as time permits, we can have a robust dialogue at the end of that. But just want to make sure that we can get through the presentation because we know we have two other people from DSS who are here to testify as well.
Thank you. I will quickly note that I'm going to continue if that's the case, because there's my colleagues, Morgan has helped me to put together this entire deck and has talked to you all before. I'm just going to continue to plow through the deck if that's all right with you. Sure. And Jen is on hand to help answer questions about Cover Connecticut. We don't have specific additional information to provide, but we're happy to help answer any questions related to the program that might be of interest. I think I can quickly move through the rest of these slides and we can move to additional questions and conversations if that works for you all. So I can quickly talk on the outreach strategies that are currently underway. The key goals of our outreach are to maximize household awareness of the program changes, to increase the accuracy of client contact information, and ensure messages are getting through. There are a lot of new requirements about how we go about doing that from our federal partners. And of course, to ensure that all the households have an opportunity to renew or to obtain new health insurance coverage. Again, that really plays into this policy of ensuring that people have that full renewal cycle evaluation during the unwinding period. Next slide, please. So the major campaign that we've been conducting to date is Update Us So We Can Update You. This is all about getting clients update their contact information so they can continue to receive the key messages from the department and from our partners at Access Health about when it is time to renew, and to keep that in. And without good contact information, the messages are going to get lost. While we are also going to be doing broader based media communications, it is really vital that we be able to communicate directly with clients directly. Next slide. So we have got the media campaign is being spread across a number of different channels. We have streaming audio and social media work that we have been conducting during our campaign, what is called out of home. So posters in all of our DSS offices, as well as on buses, the sides of buses and the backs of buses. And we've also been doing a print version of this campaign through Intercity News and La Voz Hispana. I'm going to a couple examples on the next slides of what this looks like. So this is an example of the posters that are available and can also be put up and accessed by our partners. This is, we freely share this and encourage folks to help get this message out to everyone who is serving DSS clients, especially those who are enrolled in Medicaid. Next slide, please. Here's some examples of what the billboards are looking like. I drove by one this morning. I was happy to see, and they're out and about. They are concentrated primarily in Hartford, New Haven, and Bridgeport, but that is where the heaviest concentration of our enrollees are. So that's where these billboards are up in focus too. Next slide, please. Here's what it looks like on the sides of the bus, and we've got some Bridgeport buses that are the examples here. And it's the campaign is being conducted obviously in both English and Spanish. Next slide. And in addition to the Update Us campaign that we're doing through the sort of broad-based media channels and sides of buses and billboards, we are doing direct client contact through our partners at CHNCT. So we've been doing email and automated call campaigns. They've been quite successful by the metrics of the folks who are opening the emails, who are answering and listening to the full calls. These are pretty good rates for email and robocall responsiveness. And just wanted to note that we've conducted another round in January of email. And I think you might have seen this data last time, so I'm not going to dwell on it, but just wanted to let you know that we did another round in January, which also was delivered to 237,000 email addresses. Next slide. We also wanted to talk a little bit about the planned direct outreach that we're conducting to certain populations as unwinding. We are working with CHN to do person-to-person outreach with the CHN clinical team to high-risk members. who we are anticipating would have the most significant negative repercussions from having a disruption in coverage. So each month we will be doing an extract of the number of people who are going through that manual renewal process, and we know need an additional touch to be able to ensure that they are going through the process successfully. And we're hopeful that this will really help address some of those folks who have either significant challenges or significant health situations going on, or a disruption in services would really be threatening to their health. The idea is to do this in 2 rounds. One focus at the people right when the renewals go out and they have to complete a renewal in order to ensure they don't need any assistance, or ask if they do need assistance to be able to complete that. And again, for the population who may miss that first deadline for submitting the renewal that we need to get the information back on, and they might be getting a warning notice they might close, to have that population be contacted a second time to see if there's anything standing in their way to be able to renew. We are discussing the capacity and operationalization process with CHN as we speak. Next slide, please. I also want to give a quick update between or what was issued right when you guys were meeting last week. We've got an update. We've been able to do a little deeper dive into a declaratory ruling that was issued by the FCC. Xavier Becerra, the Secretary of HHS, had posed this question to the FCC about in the middle of last year. We chimed in support of the question and the authority that we were hoping to get clarified, which was whether state and local governments and their contractors can send text messages to Medicaid clients related to the public health emergency. There's a whole host of rules around the Telephone Consumer Protection Act, the TCPA, and we were seeking clarity about the level of consent that we might need to gain before being able to contact clients via text. This decision, which came out, is got some very positive news, which they confirmed that federal and state government agencies can text Medicaid enrollees because governmental agencies are not considered persons under the TCPA, and also because by providing a telephone number during their Medicaid application or renewal process, it'll constitute express prior consent to be contacted at number regarding enrollment eligibility because of the closely related purpose for which people have provided that phone number. The caveat to this is that the FCC declined to provide this sort of derivative immunity to contractors who are working on behalf of government agencies. So there's not quite as much of a cover if we wanted to partner with contracted entities to help us execute this work. But DSS has begun texting clients. It is a relatively new channel for us to do communications. And I do want to emphasize that this is something we're going to be scaling up very rapidly to try and be able to maximize texting as another means of communicating with clients during the unwinding. So we've started a campaign with texting for people who are going through their SNAP renewal process. And now that this authority is in hand, we will be looking to rapidly expand that to be able to serve clients during the unwinding period. Next slide, please. And I just wanted to make sure that, I'm not leaving out the fact that we are partnering with a lot of other places and having other strategies to conduct outreach during this time, coordinating marketing and outreach with Access Health CT. I'm going to defer to James and his team to talk a little bit more about that if we have time today, because I know they've got some more information to share. We have a coordinated community outreach with Covered Connecticut partners that have contracted with the Office of Health Strategy. The intersection with Covered Connecticut is tightly related to how the unwinding plays out. We have long projected that the Covered Connecticut population will grow as the unwinding goes through. We've anticipated that many people who might be eligible for that program have effectively been bottled up in Husky with the extended coverage, and that they might find Covered Connecticut to be an option for them during the unwinding period. We're also going to continue to conduct direct mailing to households, email communications to those households who provided email addresses to us. And as noted earlier with CHN, we've got the posters that you saw earlier. We have video information up in our DSS offices. We're updating our phone menus so that people are aware of this, interactive voice response phone menu information. We do have DSS social media channels. We have Facebook and Twitter. You can follow DSS. I know that that's not necessarily the most common scenario for our clients, but it may help us to help spread the word to our partners and stakeholders in the program about communications message. And of course, we'll be providing provider bulletins about the unwinding to our provider partners so they have the most up-to-date information. Next slide, please. And I just wanted to reemphasize, I think you may have seen this last time, we have unwinding toolkits for ongoing updates. We're really trying to centralize the location where we have information for both clients and partners as we go through this process. We've got a nice, easy URL to remember there, ct.gov/PHE. The next few slides will show what some of those images look like. This is the landing page for recipients, trying to keep the messaging very simple. We've got some FAQs about the programs that as it relates to PHE. That's what this slide is. Not going to spend a lot of time on here. Please feel free to root around on the website. If anybody has feedback about what else they'd like to see, we are certainly open to suggestions and recommendations about how to continue to evolve this website during the unwinding. Next slide. And this is what the partner toolkit looks like. These are some of the tools that partners have to be able to help communicate around Update You, so we can Update Us campaign. You know, any partners or stakeholders who would like to take this message, put it through in posters, email your own email lists, have potentially send a postcard. There's templates for people to be able to use to sort of help get this message out, which is going to be an important message throughout the unwinding, which is make sure that that our contact information for you is as up to date as possible as we continue to communicate with everyone. Next slide. So this is the end of it. I just wanted to re-emphasize that this is really all about going through the DSS and Access Health shared system and operations. When we're talking about the continuous enrollment unwinding, the heavy volume of work is going to be going through those channels. Obviously, with the passive renewal rates, we're hopeful that it's not going to be as challenging as we might have projected before. Go through the accesshealthct.com website, call the Access Health call center to renew. I think that Matt had provided a link in the chat around the Medicaid.gov information around ex parte renewals. There's a ton of other information about unwinding if you want to see what our federal partners are disseminating to us and to fellow states on Medicaid.gov/unwinding. And that website, ct.gov/PHE, is where we want to continue to keep a sort of living message and the most recent updates for partners and for clients. Okay, I'm going to stop. That's all I've got.
Thank you, Peter. I think we're going to have a quiz momentarily. I know we have questions. I actually saw Representative Nuccio had her hand up earlier, but I don't know if she's on currently. But Representative Dathan has her hand up and has a question for her.
Thank you so much. And if Representative Nuccio is here, she can jump in. Just really, I think some of the things I have the most concern over, and first of all, thank you so much for the presentation. I love all of the graphics, and I know I can imagine every senator and representative on this call will be sharing that through all of their constituent communications and social media. So really appreciate getting those graphics. One of my concerns is currently DSS call centers closed on Wednesdays. And with a lot of folks not having access to sort of being able to do this online, are there going to be looking at how we can make sure that during this redetermination process that folks are able to get through to the agency and be able to actually talk to people?
Thank you. It's a great question. You know, I know that this is a challenge, not just for DSS, but for social service agencies around the country. You know, it is a challenge for us to be able to serve everyone in all the various channels that they want to be able to contact us. You know, I think that we are making every effort to be as accessible as possible through various channels, but also keeping in mind that, you know, one of the primary reasons why our benefit centers are not open on Wednesday is to continue to serve clients. And we spend all day on Wednesday serving clients who've chosen to interact with us online or by mail. And so, you know, that's the key focus for us during that period, is to be able to ensure that we're serving everyone across all of the channels. I also really want to emphasize that the vast majority of the unwinding population, the vast majority, is going to be going through our shared call center with Access Health. It is open 5 days a week. Average wait times, according as by our contract and our data, is under a minute. This is, you know, the front line for us for a lot of this unwinding work is going to be through that shared operational channel. And I think that, you know, I believe there's I know that there's a letter that went around expressing concern about the Wednesday closures, and to see what DS will be doing there. I expect the response will be coming out imminently with additional detail that I think will help, hopefully to help understand. That being said, it's certainly something we continue to explore. You know, I think that the agency would love to be at a place where we have sufficient capacity to serve everyone in every channel as soon as people want to. It's just something that we have to constantly navigate. We have finite resources and capacity to be able to serve folks. So we're trying to do the best we can, and without leaving out people who want to contact us in methods other than the phone.
Okay, I know a lot of things are also done face to face. What about ability to get redetermined on some sort of process like a fair or some sort of office hours, if there's any opportunities with that?
Or if you're talking about, you know, the DSS direct side of operations, so, you know, our offices are fully open Monday, Tuesday, Thursday, and Wednesday and Friday for the walk-in traffic, and they're open limitedly on Wednesday for emergency situations or people with special needs. You know, the doors are not locked; they are open. We're just trying to triage and ensure that the people who are coming really have an urgent need on Wednesday, so that we can preserve some of that processing capacity behind the scenes. I think that my colleagues at Access Health have got a lot of information they want to talk about as it relates to community events and participating and coordinating with our navigators, and how we'll be able to support additional in-person assistance during the unwinding period. So I'm going to defer to them to sort of talk through some of their plans around the Magi Medicaid QHP Covered Connecticut side of things, and how people will continue to be able to get in-person access when they need to.
Got it. Thank you very much. Thank you, Mr. Chairman.
Thank you, Representative Gilchrist.
Thank you, Mr. Chair. Just wanted, and thank you so much, Mr. Hadler, for your team's work in this presentation. Wanted to focus on the 9% increase on manual that you're going to see monthly, and just kind of looping back to what some of our first speakers said with some of the barriers they're already facing. Will there be, or could there be, an additional, like a line, like they were saying, to have the community health centers be able to get in direct access with the DSS team? Like, are there other things that could be put in place, since although it's not a tremendous increase, 9% is an increase on what seems like a somewhat strained system. So just wondering if there's any ideas.
Yeah, no, thank you for that question, Representative Gilchrist. I think it's something that we're continually trying to navigate, is how to, balance the availability of our staff time, being able to provide assistance in coordination with providers, as well as clients. Again, we're sort of just constantly drawing from the same resource pool. And so we want to make sure that we are able to serve everyone without, too much of preferential treatment, understanding that we are, very indebted to our providers for many reasons. And we want to be able to ensure that we're providing the highest level of access and assistance. With regards to the suggestion that they might be able to have more access to the system to enter data, that is something that we're taking under consideration. I can sort of preliminarily say that, most of the time the online process has worked. I understand that there's a pain point right now around Social Security numbers that is particularly acute, but historically, and to the best of our knowledge, though we welcome, specific situations if the system's not working for our partners, that it's sort of the SSN issue is an outlier. And the rest of the time that the process does work well for being able to submit applications online. So I don't want to diminish that concern, and I want to be very respectful of everyone's capacity and time to be able to assist clients. And I know that being able to data enter an application online is faster than picking up the phone and having to rehash it with somebody on the other side who's just keying the data in. I don't know about our system capacity to be able to open up our worker portal side of things to community partners. There are a lot of concerns around privacy and security and what you can access when you're on the other side of the system. And fundamentally, we have to be very cautious about ensuring that all of our eligibility rules are complied with. So there are additional restrictions. If you're able to do a workaround of the system, you have got to know how to do it and what to do legally. You may feel strongly that a person should be eligible, but there are times when people we think should be eligible or not, and the rules in the system are set up in a way to be a safeguard against that. So it's something we're going to take back. continue to have conversations about what we can do to ensure that the CACs and our navigators and community are able to continue to help people as they have been able to do so well. And we don't want to put barriers in front of that access point, but I think it's something we need to continue to talk about.
Hey, Peter, if you don't mind, let me add a little bit to your answer to Representative Gilchrist. The question about additional resources, additional help for the CACs. We plan on meeting with with many of our partners, and most of them, if not all of them, are CACs. We will be meeting with them, find out exactly what type of additional help we could provide in terms of special access to the call center. And also, one of the recommendations that can forward that can we put more of our own staff in the CAC locations so that we can enroll them directly. We are working at looking at our staffing models, see where we can be most helpful. Our CACs have been an invaluable part of our success in Connecticut, and we want to continue that. And we always look for ways to expand our own ability, as well as our partners' ability to enroll in Connecticut, because our mission is to lower the uninsured in Connecticut, and that's what we are going to continue to strive to do. But we plan to have a number of meetings over the next several weeks to identify areas of pain points for our customers, especially those who need more resources in their facilities. And we're going to be providing trained folks to the extent that possible to provide additional resources to them. And also work with our call center vendor to provide direct access with minimal wait time for our CAC, so that they're enrolling somebody, and especially right in front of them, get it done as quickly as possible.
Great, thank you both. And then, Mr. Chair, if you'll indulge me, this is kind of for a later date, but when you mentioned, now that we do know that the public health crisis is ending as of May, when it comes to COVID vaccines and COVID testing, maybe at a later date at a MAPOC meeting, just want to hear the department's thoughts on the potential impact of that. We still are facing COVID. I'm home with a daughter right now, actually, who has COVID, and she is healthy because she, I believe, was vaccinated. So just wondering, should we look at that, and what do we need to be concerned with? Thank you.
Just to say, yes, sounds good. We'll explore that and get back to you.
Thank you. Thank you, Representative. Good question. And I was going to ask that actually myself. So that was a really good question. I thought it was a good question. Representative Johnson.
Thank you so much, Mr. Chair. And just quickly, with respect to the getting the outreach there, I represent Wyndham, and probably almost 40% of my population is either on Medicaid or dually eligible, to the point where my hospital has been designated the only Medicare hospital in the state. So I would love to have more input from you in terms of the notification for the update, to maybe put it on some of our buses, and even have you, do some type of, that come out in my radio show. But in any event, I would like to be able to make sure that we get the information out. And another suggestion I have is to maybe, if you wouldn't mind, thinking about contacting public housing authorities, because a lot of the people in the housing authorities are also receiving the Medicaid program. So it might be a way for me. I know I've used it in other situations to notify people who are in subsidized housing, to try and get information out to them. So that's just another suggestion. Thank you so much for a great presentation. Thank you so much, Mr. Chair. Appreciate it.
Thank you, Representative. Representative Cohen.
Thank you, Chairman Lesser. Thank you so much. It's a really great presentation, and makes me feel a little bit better about what the monumental task ahead of us. I sit on the local CHIP board, which is, I'm not sure if you know what that is, but it is a community health improvement projects, and many of the health boards, health districts have these planning groups that come together, and most of the people, I would say, at the table every month are folks from organizations that serve this population. So I've been sort of going to the meetings every month and saying, you guys, this is coming up. This is coming up. We should make a plan for it. And they haven't really been given a heads up on it. They're not sure about it. It is through the health department. So I think just, allowing them a little bit of time to, will not only send them information and to engage with them and to allow them time to maybe do some strategy around it ahead of the process, I think would be helpful. And that's just a little bit of a suggestion from my neck of woods. So thank you so much. Thank you, Chairman.
Thank you very much, Representative. And now maybe we can begin with the, if there are no other questions from members of the committees, we could perhaps go on to the Access Health portion. I know we heard briefly from Mr. Michel. James, would you introduce your team and begin your presentation?
Thank you very much, Mr. Chairman.
And I would ask if it's possible. I know there was a lot of discussion in the first portion and also in some of the questions here that related to Access Health. So if you could, specifically with regard to passive enrollment and some other and the CACs, and if you could speak to that. I know you did briefly just now, but if to the extent that you can, if you could incorporate some responses in your presentation, that would be really helpful.
Will do, Mr. Chairman. I'm going to invite some of my colleagues to speak more about this. But first and foremost, thank you for this opportunity to share with you our strategy. I want to ground our conversation in the fact that we have been working collaboratively with DSS over the last 12 months to develop our strategy, our joint strategies. So you're going to see a lot of the information that Peter presented earlier is similar to what we're doing. But when it comes to outreach and marketing is where we are doing a lot of it that we've laid out the strategy, but they're working with DSS as well as the Office of Health Strategies. And again, that's an evolving strategy because this is the very first time anyone in the country is unwinding from Medicaid, at least in the last decade. So as we move forward, we will tweak the strategy from what's not working to what's working. So let's keep that in mind. It is a living strategy. And again, a lot of communication between us, DSS, OHS, as well as our partners in the communities, because we think that those, Peter talked about some of the folks who have not come in and update their contact information, they might be missing out. So, and again, one of our strategies is to go in person into these communities, working with our community partners where this population goes to for a lot of help and guidance to provide them the resources, the information that they need to ensure this we catch as many people as possible before any one of them have a gap in coverage. So we're going to go over some of the data that Peter talked about, but maybe a little bit more granular. Because, Mr. Chairman, I think last time we met, we said that we're going to show you the total population, how many of them would be passively renewed, and of the balance, how many of them would be qualify for Cover Connecticut, and the rest of them may qualify for subsidized QHP. So we have all of that information. We share it with the group now. And then after that, we're going to go into our marketing strategy as well as our outreach efforts. Right?
And I'm sorry to jump in, but when you say passive renewal, because I think we've used it in a couple of different contexts, you're talking about passive renewal by DSS in the way that Mr. Hadler just talked about.
Exactly.
There had earlier been a use of the term passive renewal in a different context in the sense of what Rhode Island is doing to automatically enroll someone in a no-cost QHP or a Covered Connecticut product. Is that?
No,
which are you referring to?
Similar to what Peter talked about, passive renewal into Medicaid. Now, we do have a quick conversation about what we're going to do for those who don't qualify for Medicaid. How are we going to get them enrolled as quickly as possible into hopefully Cover Connecticut or other QHP products? But my comment about passive renewal was strictly about the Medicaid renewals, where people will not have to do anything at all if they are passively renewed into Medicaid. So I'm going to move on to my colleague Rebecca McClare to go over the data that we have compiled about those who the total population for the unwinding over the next 12 months. Rebecca.
Thanks, James. Thanks, Margo. So again, thank you, Chairman, for having us here. As James mentioned, we are going to talk a little bit about data. I do want to start this by mentioning, while the data that Mr. Hadler presented in our data is based on the same, underlying information, there may be some differences just based on when his data was pulled, when my data was pulled, but the approach is the same. So I just want to make sure folks are comparing the slides and the numbers. There may be some slight differences, but it's the nature of our population. You pull the number this morning, it's different when you pull it this afternoon. So I just wanted to mention that before we get into here. So again, as Peter mentioned, we have the 12-month staggered process. So what this slide is attempting to do is to show how that overall volume of impacted households will be spread over the 12 months. So in the middle of this, you have a non-extension projection. That's the regular Medicaid volume that we have that renews on a monthly basis to get for those redeterminations. Whereas the extension projection is the number of households that are part of that extension, the Medicaid extension, that are going to be redetermined in a given month, in a given cycle. So as you can see, we have about 245,000 households that will be spread amongst the 12-month period. And we're, as Peter mentioned, we're using a kind of a first in, first out methodology. So the folks who it's been the longest amount of time since they've had a redetermination, you can see that final column, they had an original renewal date of the end of March, April, May of 2020. So those folks have been on this extension since the beginning. They're going to be the first group that we pull in to run a redetermination on and check and see where they land. And then we'll move down through the rest of the population, again, trying to spread that volume out across the 12 months the best we can. Next slide, Margaret, please. So this next slide kind of takes that volume that we're going to process on a monthly basis and then blows that out a little bit more to say, okay, once we process it through that redetermination, we're looking at a successful result, and that which would be the folks that are automatically processed and renewed, passively renewed into their Medicaid program. They don't have to do anything, versus the folks that the portion of that population or those households that are going to have to take some sort of manual action, whether that is again, as Peter mentioned, going online and completing their renewal, or calling someone, or mailing in that form. So this is where we have that breakdown. And again, this is at the household level. We all know, some households have multiple folks. They could be a household that has some folks on Medicaid and some folks already on a QHP. So this gives us an idea of the number of households impacted, but the next level down will give us a better picture on the number of individuals, right? We took that down to the next level. Before I go on to the next thing, what we're looking at is, again, about 30% of the applications, again, these are the numbers that we were working with when I put this information together, would be need to have some manual intervention to those. So that's where these numbers come from. Okay. Double check my notes. Yeah, okay. Margo, can you go on to the next one? All right, so moving down to this next slide. This slide focuses in on the extension population. So it takes those 245,000 households and looks at the number of folks that are in those households that are part of the Medicaid extension population. That gives us about 434,000 individuals that are going to be processed through this redetermination as part of the extension population. Again, our projections are using what's available in our system today. As Peter mentioned, a lot of folks maybe haven't come in and updated their information, so maybe their income or information isn't was accurate 2 years ago. They haven't updated it. We can only predict based on what we know. So that's why this is, projection. Things may change when we actually run the determinations in a given month. But based on what we know in the system, we're looking at, a spread on a month-to-month basis that the majority of folks will remain eligible for the Medicaid program they're in. So they will be redetermined and passively renewed into that a Medicaid program. As Peter mentioned, the remainder of those will come and potentially be eligible for a covered CT program or another QHP, either subsidized or potentially, if their income is significantly different, an unsubsidized program. So again, those numbers are based on what we know in the system today. So we're looking at potentially, 30,000 individuals could qualify and choose to enroll in a covered Connecticut program. When folks do come into the system and confirm their information and potentially update their information, they could be determined to be re-eligible for a Medicaid program or something else. But again, based on what we know and what we have in the system, this is what we're looking at.
So, Mr. Chairman, would it be appropriate to enter any questions now, because we've thrown a lot of information, a lot of points,
There's a lot.
Especially when you're looking at the folks who may qualify for Cover Connecticut post the passive renewals. And I think Rebecca indicated that when they come in, our process is to process them into a QHP up until the point of selecting a plan. Unlike, I think my colleague Susan Richby is going to talk a little bit about what Rhode Island is doing versus what we can do. Provide a little bit of clarity around that, but we can process them up until the point of them picking a plan. As you know, we have 3 carriers in the exchange, 3 different options. So we really are not in a position to automatically enroll anyone into a plan. So that's why we're going to ask them to please come in and select a plan. And while you're selecting a plan, please update your information, because after updating your information, you may qualify for Medicaid if your income level has dropped since the last time you were in our system.
Well, first, I guess my question is, you spoke a little bit to why we can't do what Rhode Island is doing, but then you said don't ask questions until Ms. Richby presents. Is that?
Well, no, please, if you have any questions, we're ready to answer them now.
Okay. I mean, I'm happy to, we'll follow your lead. It's your presentation.
Okay. All right. So let's get through this then at the end, because we do have more information about Rhode Island.
Great.
Sorry. Thank you.
So Margo, if we can go to the next slide. This slide is similar to the one I just talked about. This is that non-extension of the regular Medicaid population. And again, the vast majority of those folks historically and with the information in our system are projected to remain eligible for that Medicaid program that they're in, with a slight group of folks who, based on income, may be eligible for a covered Connecticut or other QHP plan. So again, as Peter mentioned, overall, based on the system updates and with the passive renewal process and changes that have gone in place, we are, while we are going to be processing a larger volume, the numbers as far as who would be potentially eligible for a QHP program are in line with percentage-wise what we normally see pre-PHE. Continue on to the next one, Margo. So this is just touching on a few questions again that we had as follow-up from last session. And we just talked about it, Senator Lesser, about the auto enrollment into a QHP. So like James mentioned, if the consumer is determined to not be eligible to be renewed by Medicaid by that redetermination process, then we'll process them through for a qualified health plan with a subsidy. But the consumer currently must take action to confirm their information is accurate and then select the plan which is right for their household. Again, we have a number of options available. Every household is different. We can't confirm or choose for them, and Susan will speak to that in a little greater detail in a couple of slides. Also, as another question last time regarding the timeline of notices and notification being sent to this population. I think Peter did mention the 2 steps in the process. The projection notice will go out 60 days prior to their coverage end date to let them know what is coming up and that they may or may not need to take action to remain covered. And then once that, as we get closer, about 2 weeks before their coverage end date, the final actual redetermination will be processed, and then they will get another notification letting them know that their coverage has been renewed and here's their new information. So those are what's sent by the system. As Peter mentioned, and Caroline, my colleague, will mention, there's other materials that may be sent out to this population, but these are the ones that are going to be system generated based on the process that we do each month. Next slide, please. One other question that we did have, I believe was asked last time, was regarding are folks out there that are, and this is not really related to the unwinding, but there are folks out there that are leaving subsidies on the table, right? Are they eligible for a CSR, but they chose not to enroll in a silver plan and take advantage of the cost sharing and the subsidies? So this slide, we pulled some numbers, and we see about 5,000 or so individuals are determined eligible in our system for CSR, but they chose to enroll in either a gold or a bronze plan. So you can see that there are some, but the vast majority of folks that are eligible for a CSR do choose to enroll in a silver tier plan and take advantage of that. So we did just want to point that out, that while there is still a portion of folks who choose not to, the vast majority do take advantage of those benefits available to them. Also, the screen, the little block on the right there, on the right side of that screen, that is popped up in our application when a consumer is in this situation. They qualify, are eligible for the CSR benefits, but they choose to, they're selecting to enroll in a bronze or a gold plan. They will receive this pop-up that lets them know they're eligible. Ignore the numbers, that just happens to be taken from the test example that I had. So it would show their particular scenario for their household. And then it would say, are you sure you want to enroll, to choose to enroll? And then they could say, no, I want to select a different plan. They go back and can then choose to enroll in a silver plan. So hopefully that gives us a little more information there. I know that was a concern from the committee last time.
Okay, just one last quick point. At the very bottom, it says if you are confused about this, if you need help picking the plan, they could click on the click help, and we'll find them a broker who would walk them through the process, make sure they're picking the right plan for themselves and their families.
Thank you, James. Yes. And on that broker point, just under half of our QHP enrollees this year did work with a broker to help ensure they're selecting the proper plan for their household, their family. So that number has been kind of steadily increasing over the past few years. So we know it's getting more challenging to understand the options. So we're glad to have our strong broker network available to help our residents. Okay, and I believe that's my last one. So I'm going to kick it over. I believe Susan Richby is going to take it from here. Thank you.
Thank you, Rebecca, and hi, everybody. If you could go to the next slide, Margot. Just going to kind of follow up on the information that Rebecca was talking about. So as Rebecca and Peter have been talking about, people are going to go through our system, the integrated eligibility system that has the rules for both Medicaid, Magi Medicaid, and qualified health plans, and the ACA financial assistance, and also covered Connecticut. And it will determine what that consumer is eligible for, whether they stay on Medicaid, whether they're eligible for a transitional medical assistance program, Peter mentioned, for another year of Medicaid coverage, or whether they're perhaps eligible to enroll in a qualified health plan, hopefully with financial assistance, which could be covered Connecticut, it could be APTCs and the cost sharing reductions, or just APTCs, or perhaps their income is at such a higher level that it would just be without any kind of financial assistance. And as people are probably aware, since 2021, the subsidies for premiums have been enhanced by the federal government through ARPA and through the Inflation Reduction Act, extended through 2025, thankfully by Congress last year. So this does enhance the assistance for everyone, and it also removed the ceiling at 400% of the federal poverty level. So more and more people are eligible for those subsidies. Obviously, the subsidies get smaller the higher the consumer's income goes. So the system will then determine that someone is eligible to enroll in a qualified health plan, and then they will receive a notice that tells them about this eligibility. And it will also, based on the information the system has, give them the amount of the financial assistance, whether that may be Covered Connecticut, APTC and CSR, or just APTC. And then, as James has mentioned, the consumer will need to come in and just pick a plan and update their application. You know, they may have additional information to update that application. And as we've all been talking about today, probably one of the most important things is that we get updated contact information from that person so that, you know, we can communicate with them. And if they are enrolling in a health plan, obviously very key to have that information so that we can transmit that to the carrier when they pick a plan so they can receive their cards and, you know, have all that information on file with the carrier. So as James mentioned, we do have 3 carriers. So there are different options at Silver, the Silver tier, which is where the cost sharing reduction plans are. And those are the plans that are used for Covered Connecticut. And for anyone maybe who is above that 175, but may have income underneath 250% of the federal poverty level, they would still be eligible for those generous cost sharing reduction subsidies. So it would be their benefit to enroll in the Silver plan. And as Rebecca was mentioning previously, that warning message also, just to note for you that when someone is going through and selecting a plan, the system does default, if someone is eligible for cost sharing reductions, it defaults to the Silver plans first anyway. So that is what they will see, and it will order them lowest price to highest price. So it'll start them right there in the cost sharing reduction plans as well. So we have talked to Rhode Island and covered California, who's also doing some variation for enrollment of QHPs after the unwind. Rhode Island does have managed care for Medicaid. So one of the carriers, one of the 2 carriers on the exchange in Rhode Island is the managed care provider or carrier, if you will, in Rhode Island. So those consumers already have a relationship with that provider, and there probably a similarity with the provider network. So they are putting them into that plan with that same carrier. California is taking a different approach. They are putting them into the second lowest Silver plan, but they are using an opt-in action required approach. They are not paying any premium for consumers, and the consumers will need to act as well in California to be enrolled into the qualified health plan. And as James mentioned, we have a very large number of brokers available throughout the state to help people, to help them look at their health needs and their families' health needs so that they can pick the best plan for them, you know, whether it be looking at the benefits of the plan and also the network, the provider network for the plan. And also very important for people is prescription drugs and the prescription drug formulary for that plan. And we have tools right integrated in our application that help people look up providers and also medications in there as well. So those can assist them if they're doing it themselves through the online application. So I'll pause if anyone has any questions, or then I can turn it over to my colleagues.
Please go on and to get through the proposal, you know, the whole presentation, and then we can circle back with questions.
Sure.
Hello, I'm Caroline Lee Ruette, the Director of Marketing at Access Health CT. Margot, can you please advance the slide? Thank you. So I'm going to go pretty quickly here just to be mindful of time, folks. In terms of what we're doing from a marketing perspective is we're working very closely and collaboratively with our partners at the Department of Social Services. You previously heard them discuss this campaign that they're running at length. We wanted to let you know we at Access Health CT are using our own channels to help amplify this campaign, which is intended to remind folks to update us on their contact information, right? So when unwinding begins, we'll have a better success rate of reaching out directly to folks and getting them to do so. So this includes social media as well as email updates to our own database of customers, certified application counselors, brokers, community partners, and a variety of other folks. And we're also working to review and provide input on co-branding for notices that DSS will be sending out in their direct-to-consumer communications for unwinding. Go ahead and advance the slide, please, Margot. Thank you. And this is what we're working on right now from a more traditional advertising perspective. This is potential, and I want to really highlight that it's potential. It is not funded yet. We are working on a Medicaid unwinding advertising campaign that would be 12 months, very targeted, including some statewide coverage, but more of a concentration on communities that have high populations of residents impacted by the Medicaid extension. Remember, we know who these people are. We have information from them at a zip code level, and this advertising effort would follow the outreach plan targeting those certain communities. So you'll hear shortly from my colleague, the Director of Health Equity and Outreach, Tammy Hendricks, about that outreach plan. And I really want to make sure that everyone understands that this suggested advertising campaign would mirror where those focuses are by her team. Again, we are currently working to secure funding for this, and the potential campaign elements could include broadcast and streaming TV. So that's your kind of traditional tune in, as well as apps like Hulu, right? If people are using things like that to watch TV, terrestrial and streaming radio. Again, terrestrial is that traditional AM, FM radio that we all grew up with. Streaming radio, things like Pandora and Spotify. Billboards, there's even mobile billboards that we can bring into communities that might not have billboards themselves, as well as posters and potentially transit. So thinking about things like bus and train systems. We're also concentrating our efforts on minority newspapers in certain areas that are highly impacted by the Medicaid extension, and potentially community-based newspapers, depending on how much funding we can secure. Also, a lot of social media, paid and organic. That way we're reaching people that don't follow our channels, as well as those people who are already engaged with us, as well as folks who are using digital platforms, search engine marketing, right? We would populate in search results when people are searching in Google, Bing, Yahoo for health insurance, as well as native and display, which is really just marketing jargon for, advertising on websites, what you see in the periphery. Again, I think, we've all talked a lot about how important outreach is and how that's going to play a really, really large role. So we have about 10 minutes left, I think, of our original time. And so I definitely want to make sure that I yield a lot more time for my colleague, Tammy Hendricks, to go through her slides. Tammy.
Thank you, Caroline. Thank you, everyone, for having us. We hear a lot of the concerns, particularly the CACs having issues. And, right now some issues are amplified, as well as some legal reasons, why CACs have to go to the call center for verification. But my team and I, we hear your concerns. And so hopefully we can try to use some different tactics to help ease that burden off of some of our CACs, and hopefully reduce some of those issues. So in terms of outreach, we needed to get a more targeted outreach plan together because this is so widespread. Of course, in-person help requires a lot of manpower. So we've narrowed it down to these target cities. And Rebecca presented earlier, these target cities stem from the data that Rebecca and her team puts together. And so we're able to break that down by county, which New Haven County takes the lead with the most users on the Medicaid unwind, followed by Hartford and Fairfield. So from there, we want to focus on the towns and cities that have the highest numbers of folks that need to get renewed. And so just to reiterate, we're looking at a much smaller group of consumers based on the passive renewal numbers, but still significant nonetheless. So this plan will outline 12 months of outreach. And of course, it's going to be staggered. And, outreach, we really try to stay flexible. We need to pivot a lot based on feedback that we get from community partners. Maybe CACs will give us feedback and we may have to go to that location. So we pivot quite a bit based on needs. So that's how I get to an outreach plan. So we go on to the next slide. Okay. I just wanted to go over in general what we typically do for outreach, and that will translate over to the plans for the unwinding period. So again, we work closely with over 1,800 community partners. And these are community organizations. These are other state agencies, religious organizations, churches, hospitals, of course, federally qualified health centers, and more. So really any organization that's interested in learning about health insurance through Access Health could be our partner. We don't limit that group. So as I say, community partners, if you have someone in mind, feel free to share that with us. We're happy to reach out. These organizations that I have on the slide, they're a very small part of our community partners list, but it serves as an example of the organizations that we've worked closely with over the years. So we do a variety of different activities for outreach. First, we focus on monthly Healthy Chat presentations for consumers, right? This link is on our website. Any consumer can sign in and attend. But these are very high-level informational presentations to learn about Access Health, the plans we offer, but also to explain the unwind period to consumers. And so that's really important that we empower them to be able to move through this process smoothly. Then we have partner presentations and regional planning meetings, which are specific to our community partners, to CACs, to brokers. These are more detailed meetings and we share updates with them. Of course, this happens to be a topic that we've been discussing with our community partners, brokers, CACs for the past year. So these presentations, again, it's, any organization, we can do them for any organization that's interested in learning about what's happening at Access Health. And so right now we're actually working on a plan to meet with all the major hospitals, hopefully get them involved in our outreach plan so we can all partner together and figure out how to help as many people as possible. So then we have our navigators, our navigator partners. We have 4 navigators, 6 locations throughout the state. They help us with outreach, but of course they also provide enrollment assistance as well year-round for consumers, and those are CACs. And so they do work closely with the outreach team, and we are trying to we try to funnel any issues, the CACs, for our navigators in particular, because we work with them so closely on a daily basis. So we try to funnel those issues that the CACs may have as quickly as possible when those come up. So again, we work closely with CACs and brokers, and we actually have 500 certified brokers throughout the state. They all attend our events. They all complete trainings every year. They learn about the PHE. They learned about Covered Connecticut through these trainings, on top of all of the updates that we send them on a weekly basis. So CACs and brokers are accessible to consumers all year round. And so that will be a huge help, especially the broker community, will be involved more as we plan outreach for this particular unwind period. So I've included a link to the community partners page. It has a directory of all the certified counselors and brokers, and you can search based on area, based on zip code, town, and it's really helpful. So if CACs needed assistance or needed to contact a broker, they can go to this link and find a broker that's pretty close by. And so, I just wanted to clarify that, CACs, they can help consumers through the application process, but once the consumer has to make a choice, then they cannot help the consumer make that choice. And so that's when the brokers step in. And we think that we'll utilize our brokers more than ever during this unwinding period. The last thing I'd like to touch on here is the Broker Academy. So the Broker Academy will play a huge part in our outreach plan as well. So this program is, we developed this program to recruit and train individuals from underserved areas to become licensed health and life insurance brokers, right? So our last class ended, in January. And we had 29 new brokers from that class. So 29 new brokers that are located in the Hartford, the greater Hartford, New Haven, and Bridgeport areas, right? Really where the highest users would probably be located. So we have the Broker Academy as well to help us filling those gaps. And then we have our certified brokers who span the statewide to help with other coverage. Okay, I'll go on to, I have just one more slide quickly. If we could just move on to the next slide. That's the last one. Okay, this would be the plan for the unwinding. A lot of information on this slide. So for the unwind, we would ramp up activities to reach as many consumers as we can. We plan on doing more presentations, more visits to our community partners, as well as adding enrollment fairs throughout the year to support the unwind. So I know that there's been a lot of mention of having enrollment staff at community organizations. That's something that we were actually considering for this. So typically we do enrollment fairs, but we were also thinking to have enrollment staff and brokers at different community partner organizations to help the CACs along so they don't have to see all of those consumers at once. So that's a really important add. Our in-person fairs typically only happen during the open enrollment period, but now we're extending it for the entire year. And we're really focusing on those underserved areas, those high touch, those people that really need that help. And our trained staff can typically get through the application on a much faster basis. We have access to the worker portal. And so we're able to assist in that way. But of course, more staff, it just the budget has to be there to expand on enrollment staff going to community partners to assist. But we absolutely are on board with that idea. And then so we'll have more monthly chat, healthy chat presentations for consumers, educating them. We'll have the Broker Academy again we're launching year 2. So we'll have more brokers in underserved areas of the state that did not have access to a broker or very limited access. So the plan is to really work deeper with community organizations, but also, this can't be done by one organization. You heard from my colleague, Caroline, you've heard from DSS. There's multiple levels here of reaching consumers. And I think once we all come together, this plan will reach a majority of the folks that we need to.
Thank you very much. And I want to move quickly because I know we have a bunch of questions and it's already been a pretty long hearing and we've got a lot to figure out. So first of all, with regard, and anybody at Access Health's team can take this, with regard to automatic enrollment and the Rhode Island model, I heard the concern that how we allocate people when we have 3 carriers, although only 2 companies on Access Health. My understanding is that Rhode Island is in the same boat. Like they have figured out a formula to allocate people between their carriers. California, I think, also has a system, and they've got a lot more than we do in terms of the number of carriers participating on their exchange. So why couldn't we come up with again an opt-out system to allocate people between Anthem and Connecticut, the two carriers, that Access Health determines is fair, and then allow people, if they don't like their carrier, to change them, so give them an opt-out period just to avoid a loss of coverage.
Susan, can you get into more detail about how Rhode Island is different, right? And be very specific about the Medicaid managed care vendor.
Yes, as I mentioned, Senator Lesser, they're not distributing them between both of their carriers. They have one carrier that is also the carrier for managed care for Medicaid in their state, and they are just putting them all in that carrier and excluding the other carrier in their state. And we, don't want to exclude a carrier. They have different networks. Consumers have different needs, and we have 3 different carriers with 3 different silver plans if you want to focus on the silver plans. And as you mentioned, 2 of the carriers are owned by one corporate entity. So, there are definitely questions of fairness for the carriers on this aspect, and also for consumers to be in the right plan for them, the right network and the right prescription drug formulary, et cetera, for their needs.
I hear that, and first of all, thank you for the clarification on Rhode Island situation. I was trying to get up to speed. Just looking at the administrative complexity, we've got a large number of people, and the biggest priority is making sure that people don't, wind up with an extended period with no coverage. Obviously, there are better plans, and there are. We can talk about, what's the best for every person, and ideally they'd sit with a broker and figure that out, specific to their needs. But to avoid the thing that I think has caused multiple legislative hearings to try to figure out what are we doing to protect people, it seems like the biggest priority is to make sure that we don't have a whole lot of people who wind up with nothing. And so that's why, I hear your concern about fairness of the carriers. My guess is that we could come up with a formula that works for them, that they would consider to be fair, and that would certainly afford, a member of public the opportunity to, make their own choice. They certainly don't want to stick someone in a plan they don't want to be in, but just making sure, we're talking about potentially no impact on someone's, if somebody's covered care Connecticut eligible, that doesn't cost you anything. So making sure that we're giving people at least some sense that they can go see a doctor if they're sick seems important. I just was curious if that's something that you'd be amenable to, if there's a way for us to work out a formula that works, that also affords people the ability to, to vote for the plan that best fits them.
And also, as I mentioned, the California approach is an action required approach. So the consumer does have to opt in. They do have to pay premium in the California approach. So it's not automatic in that sense either.
So, Senator Lesser, let us look at that and see if it's feasible for us to do it. See if we could update our system. If we can do it, and maybe we'll talk with the 2 carriers and see where they are. And see if we can do it. And see if we can get our system up to speed quickly enough to be ready by April 1st. But this is a process we have to go through, and obviously talk with the carriers and see how feasible this is. But our goal, as you indicated, is to get and make sure no one has a gap in coverage. Right?
Yeah. I would appreciate that, and I bet you they could work it out. I have a hunch they could work.
We'll talk with them.
Okay.
We'll talk with them.
And then at our previous hearing, there was a discussion about increasing the staffing level of the call center to at least match open enrollment levels. Can you give us a status update on that? Where are you, and are you going to be able to do that?
So we have our call center vendor uses data, the enrollment information, to determine the staffing level that they would need to meet the performance criteria. And our performance criteria is going to keep them as if we are still in open enrollment. So they have given us those numbers, and we are in discussion with DSS on funding strategies.
I'm sorry, I apologize if I missed that. So are we currently at open enrollment staffing levels, or are we not?
Yeah, well, we are. We're going to keep it there. We normally keep it through the end of January, early February.
Okay.
But right now we are discussing with DSS, coming up with additional funding to keep it at throughout the entire year.
Okay, and I think
in support of the Medicaid unwind.
Okay, and I think you may have just answered my next question, but I heard someone make mention of seeking funding to do that outreach effort that you were saying that's not funded yet. Is that funding that you're seeking from DSS or from your
Yeah.
Access Health Board? Who's that funder that you're at?
Yeah, both marketing and outreach effort require significant additional resources and staffing. And we're in discussion with DSS and Access Health. Now we will support part of the cost through our own budget. And then I believe DSS is looking at coming up with additional funding as well as OHS as well.
So I was surprised going back to the first panel we heard, I don't know, hours ago, about from the health centers. I didn't realize that the CACs still had to call up the call center just like anybody else, or there may be a slightly faster wait time, but it's basically the same process. Is there any kind of ability, since we've already trained these folks and you've already trained the call center workers, is there any ability to treat a CAC worker like a call center person and allow them to directly enroll?
A bit challenging because they don't have the same training, and there are a whole lot of security reasons because they're not employees. So I'll let Susan talk a bit more about that. But we have some severe limitations as to who could use our worker portal, which is a lot more flexible. You guys, Susan, give a little more about that.
Sure. Thanks, James. And Senator Lesser, we share everyone's concern with helping consumers and the CACs and anyone who's assisting them, get through this as quickly as possible. They can directly enroll them through the consumer portal. I think people were mentioning sometimes an individual might have a hard stop in the system for identity or some other kind of check. And as Peter mentioned, we are required under various federal regulations for both Medicaid and for the exchange to do checks that we do with the Federal Data Services Hub. So sometimes that is coming up because someone's got some kind of hard stop in the system, and that's when they might need to call. Otherwise, they can go right through the online application themselves. But as James mentioned, the people that have access to the worker portal, which is through our call center and DSS workers, go through a lot of vetting and checking and training because we do have a great deal of security requirements because of all the information that's in our system. And someone in the worker portal has access to anyone's application in the system, not just the one that they are working on, versus someone who goes through the consumer portal who has access to the information that they have, either that they're entering or that they're sitting with a consumer and entering themselves. So that is a different role, if you will. But obviously we'll look at what we can do through the call center to try to make that process easier for the CACs. We hear you.
Yeah, thank you. I was struck, having to spend an hour or an hour and a half or whatever on the phone seems, resource prohibitive, and also like it may not really mean that the health centers are maximally able to help speed up the process. It seems maybe duplicative. So that was a concern I had. And if there's anything that we can do to sort of leverage the CACs to better directly enroll folks, do they have? So the reason they have to have the person there is because of the ID verification. Is that the issue?
The ID verification is not so much having the person there with them. The system is checking, as we've been talking about, Social Security numbers, and we are required to ask for those. But it also checks, I think our system uses Experian. It also pulls data from the Federal Data Services Hub, and that also uses Experian data that checks identity, which is tied to Social Security number, but not necessarily completely a Social Security number. And then it's checking income information with the IRS, checking with Social Security Administration, checking with Department of Homeland Security, on immigration, all of those different factors that have to be checked for all the enrollments. But as Peter mentioned, it is a real-time check. So I would hope in most instances, it is just going through and nobody's getting any kind of, message that requires them to call the call center.
There's a couple of things we could do. We could give special access through IVR, which I think they have now, but we could ramp that up. But also, as I indicated earlier, as well as my colleague Tammy, we can add additional resources, meaning our own staff who would have access to the worker portal, and at the at some of the CAC locations, as well as brokers. Again, brokers from those communities, newly licensed brokers who just graduated from our community center, from our broker academy, who are from Hartford, Beachbridge, and New Haven.
Yeah.
So we're going to sign some of them at some of those centers as well, for them to help pick the right plan.
I'm sure all of that would be helpful. Just dumb question with regard to the brokerage, that they have the same gate as everyone else. They're going to also have to call the enrollment hotline, or what's the, or do they have their own door?
No, there's a broker portal, but it's same. They don't have any greater access than anyone else does.
Okay, I think all of those would be helpful. Yeah, I think we're just trying to get our head around the scale of it. I may have some more questions, but I want to make sure that Representative Dathan and Representative Johnson have an opportunity to ask their questions first. Representative Dathan.
Thank you so much, and thank you for this great presentation today. It sounds like you have a very robust plan in place. One of my questions stems around really, I understand about the silver plan, and if folks are no longer eligible for getting Husky, that when they go onto the website, that they are kind of directed towards those silver plans. I'm hearing anecdotally that people are not understanding what their entitlement to certain subsidies might be until very late in the process. So they see that the potential cost for the plans might be quite high, and so they don't have that understanding about what their net cost is going to be. How is Access Health going to address this so we make sure that people don't see that sort of sticker shock and then all of a sudden realize that, oh, actually there is some more discounts ahead? So we'd love to hear what the sort of updates are on the website for that.
Sure. Either Rebecca or Susan, can you guys provide some clarity around that?
Sure. So the process for the application, when they go through the process to get to their eligibility determination, right, that uses all their income information to determine how much subsidy, right, they're eligible for. But we don't really know exactly how much of that is going to apply to their policy until they pick a plan. So on the shopping page, it does say, here's how much the premium is with no subsidy. And then it does have on that screen, after, this is how much we expect you to pay after your subsidy is applied. So when they see that, it's on that shopping page of, here are my options. So it is there. It is, I admit, it may not be as prevalent as folks might like, and we can certainly take a look at redesigning those pages to bring some of that information to the forefront, or use some colors to make it a little, pop out a little bit more, for sure. But that's where they do see that. And then once they pick their, choose their plan, they go, the next confirmation page has it out in a little bit more detail. If they have multiple people in the household, how much the total is. And if they don't, they can always go back and pick a different plan if that doesn't work out for them. But that's the series of steps. But I hear you, it sometimes the bigger, if the number that you see in front of you is the before your subsidy number, you're not even going to look down to the next line.
Well,
so we can definitely look at that.
Yeah, and I heard from folks that they didn't even see any subsidy on that shopping page at all, and it wasn't until very late in the process that they actually saw what their cost might be. So I do think, making it stand out a little bit more for folks, I think would be useful. The comments I heard about this were last summer. And so unless you have totally changed it since then, it's it's still an issue. So I don't know if maybe you could share a couple screenshots with the administrator so that we can kind of get an understanding of what you're talking about, so that we can, if we do have questions or complaints, we can kind of highlight it. But I do think folks need to see that, this is pre-subsidy, and maybe, you are eligible up to subsidies of X, which will be, highlighted after you fill out all your information, or however you handle it. I'm not a web designer, so I will let you guys do that. But just wanted to pass that along, because we really want to make sure that folks don't go and not get their insurance because they think it's going to cost too much money. We want to make sure that we make it as simple for them as possible. So thank you so much, and really appreciate everything that you're doing. I really liked hearing all of the outreach opportunities you've had. Thanks.
Thank you.
Thank you, Rep.
I just want to check, we'll take that suggestion back to pull some screens and provide some examples to the chairman so we can share those out with you for sure. Thank you.
Great. Thank you so much. And thank you, Representative Dathan. I do really appreciate also the offer to go take a look at working with the carriers on the potential allocation issue. And some of the comments back and forth on streamlining the process for CACs. I thought that was really helpful. And just, Mr. Michelle, just one clarification. Would you be willing to have someone from your team meet the next couple of days with representatives of the health centers to sort of go over some of the details of that? Is that something that would be?
Absolutely. Sure. And as a matter of fact, we plan to have meetings with all the health centers, and specifically around the end of the unwinding of Medicaid. So that's in a process of being scheduled, and so we'll, as Tammy indicated, we're going to present to them the opportunity to staff up some, especially the areas where that has the highest concentration of unwinding Medicaid recipients.
I think that would be great. Also, just troubleshooting, just having sort of conversations back and forth about how
made it out, huh?
If that's possible, having a back and forth conversation about how to streamline the process. I think they can see from their end, and I'm hearing from a bunch of them right now that they think that would be helpful. So if that conversation can happen, I'm happy to facilitate it, or you guys can connect directly. Either one would be.
We know all of them, so we will connect with them directly.
Okay.
Get the ball moving tomorrow or Monday at the latest.
Fantastic. Thank you so much. And Representative Johnson, so you have your hand up.
Thank you so much, Mr. Chair, and thank you for this amazing presentation. A couple of questions that I'm just wondering, I missed the first part. Did you discuss long-term care people who are unwinding, those also in facilities, and those who may not have a place to go to if they're no longer in they've been in a facility for a while and may not have a home to go to? So I was just wondering if that was part of the discussion. If not,
we did on the first panel, we did have two representatives of our long-term care facilities talk and discuss a number of issues. So we did have a back and forth, and we had one with DSS earlier. I think that's really more about.
Okay, well, I would just like to follow up on that, because I'm wondering if the long-term care situation is going to be a determination based on not just money, but also what the type of care is that the person gets. Was that?
So you're asking Representative, we've had a discussion about that. I don't know if anybody from DSS is still on and wants to weigh in on that, but I think we did have a little bit of a discussion.
Sure. I don't know if we wanted to help with that or not, but that's one of my main concerns, is that there will be people who say the facility doesn't think that they're going to get reimbursed from Medicaid based on the change in the winding down situation that we're in. And so that is a concern of mine. And it's also a concern that we're dealing with respect to discharge planning from hospitals to wherever. So that is something that it looks like it's because of changes in Medicaid. So that's one of my concerns. And then the other one has to do with, I'm pretty sure that the Access Health Connecticut doesn't do anything with Medicare supplements, right?
No.
You don't do any Medicare supplements.
No.
Okay. Yeah, I just want to confirm that. And then finally, also with respect to getting the information out about the winding down, we do have in town also one of those electronic billboards that changes all the time. And that would be another place where I could help you get that information out to the people and have it there fairly regularly through this process. So I'd like to be in touch with you on that. But if I could check in with Gui at some point and talk about level of care issues that I seem to be hearing about, it would be a big help. And sorry I was late. Thank you so much for the great work you're doing.
Sure, and Representative, absolutely send me this is Guy Wilson here. Send a note and would love to connect. Thanks.
Thank you.
Thank you. I think that are there any other questions from members of the committee? If not, I want to thank all of the presenters for the additional information presented today. This has been helpful. I think we still have more information we're going to need to get, and there are a lot of questions, particularly from Access Health, questions about pending funding, and then a couple of other questions that were raised today that we'd love to hear back from you on, and exactly what that format, whether or not we're going to have another informational hearing or some other process, I think remains to be decided, but it would be really helpful if you could share that information with the members of the two committees as quickly as possible. And then, just one last thing, I do want to underscore a question I had about the CACs, and if there's a way that my office can be helpful in facilitating the discussion, I think that would be welcome, and discuss online what that would look like offline.
Thank you much. Will do.
Thank you very much, and really appreciate it. And thank you to all the panelists